So it looks like Professor Morrow has joined us.
Yes, I believe she is here now.
Yes, I'm here. Sorry, I was doing dishes while listening. Let
nice,
me,
nice to see
I'm
you,
doing
so to
this.
speak.
Yeah, let me get there's my camera. Okay. Hi, nice to see you.
Likewise.
So, I don't know if Kate had another question popped up, but since you said something about me being here, I had a question, or actually just more a request. For the students who are here, will you tell them a little bit about how Loyola has been involved with DACA students and getting them into medical programs and into residency programs? That was
Sure.
just so cool when we first met. And I mean,
Oh,
all the stuff you talked about was cool, but I really appreciated learning about that.
sure. I'd be happy to talk a little bit about that. The you know the Deferred Action for Childhood Arrivals program, is also known as DACA. You may have heard of it. It's for undocumented young people. In other words, people who came to the country as children. They were brought with their families, and so they came at a young age. They grew up here their whole lives. They start reaching the age of maturity, and very often they don't even know they're undocumented. And they're going through school with their peers, everything seems normal, and they get to the age of 16 or so, and they go to get a driver's license, and their parents have to tell them you can't get one because you don't have a social security card, you have no lawful ID. And so they are undocumented. And President Obama in 2012 created the Deferred Action for Childhood Arrivals program for these young people, um, which is not a pathway to citizenship. It's simply um, it's what it says. It defers action on their immigration status for 2 years at a clip. If they're over the age of 16, if they arrived prior to the age of 16, have lived here for more than 5 years, have a clean criminal record, and are either have a high school diploma or the equivalent, or are currently enrolled in school, they get this 2 year stay of action, and they get a work permit, which is really handy to have a work permit so that they can work lawfully and earn wages. And the medical school I'm at, the Loyola Strip School of Medicine, was the first medical school to openly say we welcome applications from these young people, because undocumented youth that had no opportunity in the past to go to medical school. And we were hearing about some who wanted to go. And we said, okay, you can compete on a level playing field, and we will help you find a way to finance your education, because they are ineligible for all federal student loans, all federal benefits. And so we have currently in our medical school 18 DACA recipients, and 24 more have graduated our medical school since we started this and are in residency programs around the country. And that's out of probably what we believe is now, that's 42, and we're out of what we believe is close to 200 nationally. The rest of the country has done about 160, and we have these 42. And just because we believe that it benefits the physician workforce, brings a diverse work pool, they compete on a level playing field, and we all benefit from that.
Can I ask a question about that?
Sure.
Like when you started with that program, since you were the first one in like I think the United States, how did you even go about, I guess, approaching that subject to like the school, and then also just I guess because that seems like something that also maybe I don't know federal government might have a hand in. I guess how would you I guess
Yeah.
even start that?
Yeah. Well, I'd had an interest in undocumented um, people generally, as a bioethicist. I've been running into this in the hospital, and so and it's probably worth saying that I'm a bioethicist. I have a PhD. I don't have an MD. My PhD is in philosophy, and I've worked for 30 years in medical schools, and done clinical ethics consults over in the hospitals that are associated with the med school. And so if there's a sticky decision going on where somebody's trying to figure out, um, the doctor saying, oh, we should stop the ventilator and things like that, we're not really helping the patient anymore, and the family say, no, keep going, or vice versa, the family sometimes saying, we should stop it. And physicians say, no, it's too soon. They can call an ethicist like myself, and we come over and help sort that out. So when things get thorny, they sometimes call for an ethics consult. And I started seeing undocumented patients periodically in the hospital. Um, because typically, undocumented people don't typically consume a lot of healthcare resources for a simple reason. Immigrants tend to be fairly young. If you think about it, who migrates? It is not old people, right? Old people don't get up and move their life and come across a border and walk across a desert or get off a plane and overstay a visa. Older people tend to stay put. So it's young people. So young people are healthier, and so they don't tend to consume many resources. But young people do sometimes have things like accidents. Injuries are a common thing that happens with young people because you are physically active. And so, for instance, I remember a case very vividly of a young man. He was in his early 20s, was a construction worker, had a severe accident on the construction site, was in our hospital, and he was stabilized. And as EMS people, you all know that hospitals have to take everybody in an emergency, right? If a patient presents in an emergency, it doesn't matter if they're insured, uninsured, their immigration status, any of that, you have to take them in until they're stabilized. And once they're stable, you can discharge them. But this patient would came in and he was stabilized, but he needed significant rehabilitation and other things. He could not walk out of our hospital. And normally, in the way the system works, being uninsured, that Medicaid would take care of him eventually, and he could go to a rehab or a long-term care facility till he learned to ambulate again and all of that. But because he was undocumented, ineligible for Medicaid, that's a federal-state partnership. It's a benefit, and so stuck in the hospital, and they said, well, what are we going to do? Well, he's going to be here for months. We don't just keep patients in our beds for months. They called the ethicist and asked questions like, can we send him back to Mexico? Put him on a plane? It's like, whoa, let's think about that for a minute. If we do that, what are the ramifications of that ethically? And if it gets out in the community that we're deporting people who get injured medically, what are people going to come in when they're sick? And as we know, with the public health crisis like COVID, you want people to come in when they're sick. Otherwise, it jeopardizes the rest of the community. So I was reasoning out things like that. And I started getting really interested in these issues confronting undocumented patients. So when an email came to somebody at the university about an undocumented student who had a 3.9 GPA, and she was bilingual and bicultural and had all these service activities. And the professor, who was a math professor, said she was the best student he'd ever seen, but she was undocumented because she go to med school. Some people said, what do we do with this email? And eventually somebody said, send it to Mark. He talks about that stuff all the time. And so they sent me the email, and I started researching it. And that was in 2011, just before the creation of DACA. And at the time, because there was not the Deferred Action Program, I figured out that we were able to educate her. There's no law against educating a person who's an undocumented immigrant. Universities occasionally would do that. The problem was when she graduated, she wanted to go on to residency. She had her MD's. Residency is actually a job as well as a training program. You get a paycheck in residency. And so without a way to work lawfully, she would be stuck without being able to go on. And so we were a little bit stumped as to what to do. But then came June 15th of 2012, and President Obama announced the Deferred Action Program. We heard about work permits. And so that was then like, okay, we've got everything we need. If she can get a work permit, we're good. And because I'd already been researching this and talking to our dean about it and all of that, and we are a Jesuit university. I don't know if you're familiar with the Jesuits, but they're an order of Catholic priests who founded places like Loyola, Creighton, and Omaha, Georgetown University. And they're very social justice oriented priests. That's one of their big things. And so it's the university's mission and ethos was kind of in line with that, as well as the fact that most Catholic universities were founded about 100 to 150 years ago in the US for the last wave of immigrants. Back when Irish and Italians were arriving, and the signs were up saying no Irish need apply. And so this was it's in the DNA of Catholic universities. And so there was a willingness to kind of recommit and take a step like this. And so the dean said, let's do this. And, we tried to, but the big challenge was finding some financial aid for them because they're ineligible for federal student loans. And most medical students, as you may know, use lots of student loan money. The average medical student graduates with about $200,000 of debt in federal student loans. Now, you don't have to worry too much about that. Well, that's a lot of money. Doctors pay their loans off in 10 years all the time. Doctors don't default because they make a lot of money. So it's not just how much you borrow, it's your debt to income ratio that matters. So, but we had to figure out ways to finance them. And so it wasn't a hard sell at our school to do this. But we've tried to influence other schools. I'd say there are now other places taking these students as well. And we've had some close calls because President Trump tried to rescind the DACA program because it's created by an executive order of the last President Obama, and President Trump did rescind it. However, the courts held it up, and we got a favorable ruling in June from the Supreme Court that he didn't do his due diligence. It was a procedural thing, and so it was upheld. But of course, he would go through the procedures again and rescind it again, except that he just lost re-election. And so DACA will remain open. But ultimately, these young people need a pathway to citizenship. DACA is a little bit of a flimsy reed to keep hanging our hats on. They need to be able to get federal student loans. The numbers would be much higher in medical schools if every school that took a DACA recipient didn't have to figure out how to finance them if they could just get a federal student loan. But I guess I'm sort of into my talk here, and I'm not showing any slides. But I'll just keep talking if that's okay. You can interrupt me when you have a question. The thing about medicine is, whatever you think about immigrants, right? Patients are patients. You need to treat a patient a certain way. It doesn't matter whether they're an immigrant. It doesn't matter if they're a criminal. I mean, doctors and nurses and healthcare professionals have to treat a patient and try to make them better, have to treat them well. We have a very renowned burn unit at our hospital at Loyola. People who get severe burns are hospitalized there. At one point, we had a number of years ago, we had 2 children who were there who had been gasoline thrown on them by a parent and had been immolated, and people were taking care of these severely burned children. Not far away in the same ICU, we had the father who threw the gasoline on them and got some on himself and got some severe burns. And those physicians had to treat him with all the same skill and attempts to make him better as they treated the children. Because doctors don't hand out punishments. That's for the courts, that's for the justice system, it's for other people to do. And it's the same in wartime, right? If enemy combatants are brought into the medical tent, they have to be cared for. And so for medicine, with undocumented immigrants, it's the same thing. Whatever one thinks about the immigration system, our health system needs to be caring. They need to feel safe when they come in. They need to be treated, and we have to try to figure out how to set up the system to treat them efficiently. Because, as you know, the emergency room door is the one that's mostly open to people, but that doesn't really deliver care especially efficiently for chronic problems, for ongoing problems. So for instance, if most undocumented immigrants have been here now in the country more than 10 years. 2/3 of all undocumented immigrants have lived in the United States and worked here for more than 10 years. So we have this image from the news that lots of undocumented immigrants are flooding into the country. It's not actually true. Most have been here a long time. Our immigration flow is actually not very high right now compared to the standards we've had for the last 15 years or so. And so, but when you're here for a longer time, you do start to get some of the chronic problems. Remember, young people, when they get here, they don't consume many resources. Once they've lived here a while, 10, 15, 20 years, middle age is really hell when it comes to your body. And so there are people that then sometimes do get things like diabetes, and diabetes can cause things like renal failure. Your kidneys start to fail and you need dialysis. And think about being uninsured and undocumented in the country. You go to the emergency room because you're having problems from renal failure, and they have to stabilize you, so that they put you on dialysis and they dialyze you. You feel better. They discharge you. What happens? Well, you're still in kidney failure. All the toxins build up in the body. You end up getting sick again. You come back to the emergency room 5 or 6 days later. They dialyze you again. Out you go. But now you're only coming in when you're in the emergency, right? That's not a very efficient way to do dialysis. That will cause other bad things to happen to you. It's much better to have regularly scheduled dialysis 2 or 3 times a week, so you get the toxins out of the bloodstream, and you actually live a pretty decent life. And so hospitals face this dilemma. Well, we only have to provide the emergency care, but you want to provide care efficiently, right? You want to be a caring institution that does care efficiently. So you have to figure out how you're going to get dialysis to these patients who are coming in like this. And so then it gets into the issues of charity care policies, or how do you manage this? An interesting fact, most hospitals don't own their dialysis unit. There are 2 major private companies in the country that own most of the dialysis units in the nation. And hospitals subcontract contract with them for it. And so many hospitals will use their bargaining leverage with the dialysis company and say, okay, what do you say we split X number of patients who are undocumented or coming in? And so we'll have 5 slots, say, for undocumented patients, and they'll split the cost of that with the company. And when those 5 slots are filled up, unfortunately, then the rest are coming in and to the emergency room, or maybe they go try to find somebody else's emergency room. And these are the difficulties. But again, when you think about where's healthcare's moral compass, it's in trying to create systems that are caring, efficient, and do tend to also to the public health. And one of the reasons we want to be caring and we want people to feel safe coming in, no matter whether they are undocumented or a citizen or a criminal, as we just talked about, is because it keeps everybody healthier in our country. And the pandemic has just demonstrated that to us. If people don't feel safe getting tested, coming into a medical facility to get tested, they will keep spreading virus, right? And so it's really to all of our advantages if people think of the healthcare place as safe, not as a place where if you are in some trouble with the law, they'll turn you in, you'll get in more trouble, whatever. It needs to be a safe place. And we've been through this with other kinds of populations too. People who are using illicit narcotics, right? You want them to be able to come in and not feel that you're going to call the police. They need to be able to come and get treated, otherwise they'll spread hepatitis and things like that. And so our institutions have to think a little differently than the rest of society does. And so we have to figure out these ways to get appropriate care to patients, and also to reassure them that they are safe in our facilities. And so the difficulties do come in with these chronic care situations, questions about how to discharge these patients, and all of those kinds of things really are the kinds of things you would confront if you become, say, an emergency medicine physician. How do you make these folks feel safe? And of course, some of the patients are children, and it's even less humane to not treat children equitably. Approximately 33%, the full 1/3 of undocumented children in the United States lack health insurance. And that's actually, they're doing better than their parents. About 45% of the adults lack health insurance who are undocumented. And a few states have some state programs to help them out, and it's the ones you might expect: California, New York, Illinois, my home state, Massachusetts, Oregon, the state of Washington. But the other 44 states do not have any kind of health insurance program that would accept undocumented children. And so they're also out in the cold. And so where do people go? The emergency room, as we just talked about, is a common entry place for people. Once they get into the emergency room, then it does become either just doing the minimum, or the hospital comes up with a charity care program in some sense that uses funds devoted to charity to provide ongoing care for things that are beyond just emergent care. Some places have, I've been working with colleagues around the country to try to figure out how people are getting care. And some of them have in high prevalence areas, in areas where there are large groups of undocumented patients, will actually set up networks of care among them, coordinate this, because they know they're going to use charity care dollars anyway. They might as well work together among the hospitals and clinics in the area and use those dollars efficiently to get people. And so, like, for instance, one colleague in North Carolina was telling me about her hospital being part of a larger network that does actually undocumented immigrants could come in and qualify for a plan, and they actually give them a little card that looks like an insurance card that entitles them to benefits at this group of clinics and hospitals. And you can imagine the beauty of the card. It might sound silly, but the people don't actually like to come in and ask for something for free. To show up at the desk and say, I want you to give me something, but I can't pay you. That's hard for anybody. I mean, we sometimes get this image in our heads of people who are immigrants and stuff wanting a handout. People hate handouts. People want to earn their keep. They want the dignity of being able to say, I'm paying for this. And so having the card enables them to walk into these clinics and show it, and that's their health plan essentially. And the admitting clerk knows what that card is, and that they have a source of funds that will be paying for this through the health system. And that's incredibly superior to other networks, like, for instance, a system I know in Wisconsin that does great work. The hospital devotes a lot of funds to charity care, and they try to, they have a meat packing plant nearby and some agricultural workers and the dairy farms in Wisconsin. And they try to let it be known in the community that you can come in and talk to a social worker, and a social worker will sort of pre-approve charity care, even for primary care and all that. But they don't give them a card or anything like that. So every time they come in, they have to explain the situation again to the desk clerk. Well, they don't tend to come in very often as a result of that, because they don't, in each you can imagine desk clerks turn over. They don't always know what people are talking about, all that. There's a real uncomfortableness and lack of dignity to that. And so these networks that actually set this up then can meet the needs as they're ongoing and try to negotiate among themselves the different clinics and hospitals, which needs will be met by which group and things like that. And that's a much superior system. Unfortunately, as with any kind of charity system, there's always gaps in the system. There's sometimes services that are not available, unmet, things like that. And that can have huge impacts on the quality of life. Or sometimes there's a wait for the services. And I heard from one of these networks about having a patient who had to wait a full year to get a surgery. And her quality of life was hugely impacted. Her mobility was impacted because she needed the surgery. And she had a toddler at home. And you can imagine your mobility is limited. You have a toddler, and you're waiting a year for the surgery and to begin your rehab. And that's the kind of things that happen to folks. One thing I should also mention is that if you're in major cities, major urban areas, there are something called federally qualified health clinics, FQHCs. And these are nonprofit organizations. They're primary care clinics. They work on a sliding scale model of payment. And so they're funded largely, at least in part, through federal grants plus whatever payments they're able to collect. And they ask nothing about immigration status. So many patients who are citizens get their care there who are very low income. They get all their primary care there. But undocumented patients also are able to walk in, and these are tremendous sources of care in the United States. And in fact, I just looked at a statistic. 1 in 11 people in the United States get their primary care through a federally qualified health center. And just to show you how things don't always have to cut the way we think they do with political parties, you know who increased the funding the most to federally qualified health clinics? Which president? George W. Bush. It was, he had a fairly large amount of the Latino vote. He was considered pretty immigrant-friendly president. He actually tried to pass immigration reform, but he did not get it through Congress. But he devoted a lot of funds to FQHCs and really expanded their reach. And I say this just because right now we're in an era where the parties are very sharply divided, and we tend to think of immigration as really the progressives are on one side of this, on the Democratic side, and all the people who are kind of regressive about this are on the Republican side, and never the twain shall meet. That's our moment in history right now. The last person to do an amnesty for undocumented immigrants was President Ronald Reagan in 1986. He gave amnesty to 2.1 million undocumented immigrants, and that was the last major amnesty in the country. Because it's also a Republican way to thinking about the American dream and working your way up. You pay your dues, you've lived here long enough, you've struggled to get by, and then at some point we say, okay, come on up, and we're not going to block your way anymore. And that was the President Reagan approach to it. As I say, and then George W. Bush also had compassionate conservatism and reached out to this community as well. And truthfully, some of the most draconian laws that we're suffering from right now, including a law on the books that says that no undocumented immigrant can qualify for any federal benefits. And that law is actually what keeps DACA recipients from getting federal student loans, was signed by President William Jefferson Clinton. And so, because he wanted to show he was tough. He wasn't a bleeding heart liberal. And so, this is not always cut one way or the other politically, and it doesn't have to. Immigration should be something that we can really come to some agreements on, because it is good for the country in most ways. We are a nation of immigrants. If we stopped letting any immigrants into the country tomorrow, our population would begin shrinking. We're an aging nation. We have low fertility rates in the country at this point. And so immigration is the lifeblood of keeping our population stable and keeping our demographic pyramid from completely inverting. And all us old guys who are going to be collecting Social Security in a few years really need young people working and paying into the system. And so immigration is good for that. And we need to continue. It's the lifeblood. It's where the talent comes from. And so that should be neither a Republican nor a Democratic issue. And it is, part of what goes behind our DACA program at Loyola, which is the thought that young people should be encouraged to reach their potential. That's good for everybody. Keeping people in jobs for which they're clearly capable of much higher education, much higher skill levels, being able to produce more, being able to start their own clinics, their own businesses. That's good for everybody. Immigrants are the most entrepreneurial class. They start businesses at huge rates. They are job creators. They are not job takers typically. And so this is just something that we should all be able to get on board with. But for right now, we're still in a situation in which we've had a lot of anti-immigrant rhetoric. The immigrant community is afraid to come into our clinics, afraid to come into our hospitals because they're not sure what our relationship with law enforcement, with immigrations and customs enforcement is. So part of what we've created at Loyola is also a website called Sanctuary Doctoring. And we have materials on there for physicians to use to help them put their immigrant patients at ease, to think about things they should say to them. For instance, reassuring them that you will not write a patient's immigration status in their chart, because they don't know what you're putting in. You're sitting at the keyboard clacking. They're afraid that you're recording things that your suspicions, or if you know that they're undocumented, because when you ask them, oh, can we sign you up for Medicaid? And they have to tell you they're not eligible. They, they're pretty sure they know why, you understand why they're not eligible. And you have to reassure them that you're not going to put something like that in their chart and potentially endanger them. So there's things like that we talked about. The website has pamphlets on it, flyers that people can download and adapt to their health system, that also talk about things like legal resources, because some people are actually eligible to adjust their status. Most undocumented immigrants are not, but some are, but they just don't have the legal resources, talking about putting on their pamphlets where they can get sliding scale cost legal resources available and things like that. Caitlin?
Sorry, I can't figure out how to do the raise hand off function.
Sure.
So are there physicians then who do report immigration status, or is that like illegal to do, like to report that on a chart?
Yeah, it's not illegal. Now, people put it in the chart innocently enough. They don't necessarily mean to be causing any problems to the patient. But again, they sometimes when it's like, okay, normally we'd get this patient signed up for Medicaid to cover this care. They put it in there, oh, they're not eligible for Medicaid because of being undocumented. And so they need to be told, really, you need to leave that piece out. You need to say they are ineligible for any federal or state benefits or something like that, and just leave it at that. Now, in terms of turning them in, it doesn't happen very much. There are isolated cases that are seen in the news where somebody has called immigration and customs enforcement, often in border towns. But generally speaking, it doesn't happen very much. There are people who, as you can imagine, if you have a health system like Loyola has, that employs 10,000 people, there are going to be people who have certain political views about this and resent these patients, and will say things, and you're always a little bit worried about them, but they, for the most part, tend not to do it. We just have to teach them more about, again, going back to that, you need to treat every patient the same, regardless of these feelings. And that's more the tack that we have to take with them. But reassuring the patient that you won't write immigration status in the chart is the important thing, because they don't know that you're not going to do that. And helping them access resources, as I say, is the other key part to that. So that, and a lot of times physicians don't want to open these cans of worms, because they're like, what do I know about this? They're going to start, they're going to start talking to me about this stuff, and then I won't know anything, and all of that. When I do workshops for physicians, sometimes I just make them open their laptop or their whatever device they have, a smartphone, and just open Google and put in legal resources, immigrants, and their community, and they're surprised how much they can learn. And in the workshop, we fill out the pamphlet with the local legal resources, because there are immigrant advocacy groups, there are groups through law clinics and things like that that are available. So you can often find resources to help your patients. And some simple things that we teach physicians to do as well. Is to tell the patient, the adult, to make sure that their child's emergency contact information at the school is kept up to date, so that the emergency contact name is who they would want the child to be picked up by and cared for if something happened to the adult. And the implication is if they were to be picked up by immigration and customs enforcement, that the child wouldn't just go into foster care or something like that while the parent was detained. And it sounds like it's a parent's worst nightmare, isn't it, to be separated from your child like that. And it sounds hard for a physician to say something like that, but we always say, trust me, they've already thought about that. They've already thought about the worst case scenario. You're not the first person putting that in their mind. You're empowering the patient to do something so that they're not just a victim at that moment, that they can still take care for their child. And so those are the kinds of things that we work with physicians to make sure that they're doing with their patients. Um, yeah, that's pretty much everything I've got to say. But feel free to unmute yourself and ask questions or make comments or anything you'd like to say.
So I guess I have a question in regards to like anti-immigration rhetoric.
Mm-hmm.
So I'm from a small town in South Dakota where, typically there isn't a lot of, different people. So I feel like when people don't leave that town or leave the area, they don't interact. And so they see all the headlines with all the scary sounding rhetoric, and they latch on to the anti-immigration rhetoric. And I'm just wondering what tips you have to kind of change the like the topic, or like try to change their minds and like leave them better, because especially when you're talking about how you always hear the rhetoric about how immigrants are a drain on the medical system and stuff like that.
Mm-hmm.
And so even for someone like myself who's tried to be a little more like open-minded, I had no idea that they typically are healthier, and stuff like that.
Yeah, and you're asking a great question. Because this is the big problem. I mean, diversity does change people's attitudes, right? If you live in an area where you get to know people, it changes it, right? I mean, the immigration is just one example of that. Certainly, gay and lesbian people also have went through this, a couple decades ago, where much of the country was very anti-gay and lesbian, and as people got to know more people, the whole coming out movement was about really changing the image of who a gay person was. That it could be your brother or sister, it could be your child, and as people got to know people better, attitudes changed, right? Attitudes changed. That they're just human beings like the rest of us and should have same basic human rights as everybody else. And so the coming out of the closet movement really changed a lot of that on the LGBTQ issues. And to some degree, that's what undocumented immigrants have tried as well. And it's part of what we do at Loyola. Now, out of our 40-some students who we've had, students and alumni who we've had who are DACA recipients, about a third of them do public speaking. The other 2/3 remain private because of fears for their family. But part of it is to change the image of who's undocumented. It's the meat packing plant, it's the person working on the farm, and it's your doctor. And so that's part of it, is the more people are willing to look at these stories. Stories change people's minds. So as you come to know people, to share those stories with others, what I'm surprised isn't more effective in the United States is just our own family stories. Because in a sense, every family has an immigrant story, pretty much. I mean, with some exceptions, right? Native Americans and African Americans were often brought here forcibly. It's not your typical immigrant story. But for the most part, most of our families have immigrant stories, and recalling those and the opportunity that America presented. And those stories are powerful. I mean, those people who first came here, whether it's your grandparents or great grandparents, they left places out of fear or out of an inability to feed their families in those places, and they came to this country. And I know in my family's case, my father's side, my grandfather came here and worked in the coal mines in Pennsylvania, and really worked himself to the bone, and eventually was the victim of a mine collapse, and died from that. And yet the family was so proud of working hard and even dying at work to make something for their family. And to ask, why do people think that these waves of immigrants are any different? But they're not. I mean, they're working at the meatpacking plants 12 hours a day and getting hurt and getting injured and having nothing to show for it except for their child being able to go to school. And that's what they are asking for. The other, the huge inaccuracies in this, that's probably worth mentioning to people. Right now, about 50% of undocumented immigrants in the United States are of Mexican descent. That was at one time as high as 60%. It's actually shrinking because um, immigration is not mostly coming from our southern border anymore. It's coming from Asian nations. Most immigrants to the United States currently are coming into the US from Asia. That normally startles people because we're so focused on that southwestern border. And so as a result, insofar as the undocumented pool is not actually growing, it's probably staying in that 10 to 12 million range. The composition is shifting a bit. So it's shifting much more Asian because undocumented people come from the same places as documented people. Because our system is a quota system, essentially. No nation can send more than 7% of the immigrants we take in a given year. So some countries that are that there are a lot of people who want to come here. For instance, India and China, lots of people want to come. There's a huge backlog in being able to come here, and then some will get here on a visa because they have to get off a plane. They're not coming across, sneaking across a border. They get off a plane. They have a visa in hand. Because of the backlog in our system, we're not adjusting those people onto a path to citizenship because the quota fills so fast. The visa expires and they become undocumented. And so we have these folks then who are considered unlawfully here at that point. And so that image, because it does change. People have a different image of Asian immigrants, right? They think of them as coming here wanting to go to universities and all of that kind of thing. And all that's true. And so the more people can get to know about these stories and connect with them, the more attitudes tend to adjust a little bit. We dramatically need some reforms in our laws so that we don't just keep making these pools of undocumented people and creating the situation for ourselves. But yeah, in places that are that are not very diverse, the stories aren't told. People don't get to know people face to face. Attitudes change a lot more slowly. It's just difficult that way. I wish I had a more satisfying answer for you, Debbie.
No, that was a really good discussion. Thank you.
Hey, sir. So I had a couple questions.
Sure. Nice to meet you, Jacob.
Good to meet you too. I'll just quick introduce myself. My name is obviously Jake. I'm a first-year freshman here at Mines. I'm majoring in biology. So my first question is a little bit off topic. I think it still kind of relates to this discussion. But could you kind of highlight on the ethical dilemma that you face with contact tracing? Because of course you can't just force people to stay in their houses. So how do you get people to stay home, and where do you kind of cross that line of going too far? I apologize if that's off topic. But.
Yeah, no, give me some of your thoughts about that. I'm happy to react to it, but tell me what you think.
Yeah, I was kind of going off of what you were going to say, but I guess I'd probably have to say that it would be kind of an invasion of someone's rights to force somebody to stay home. And I think it really has to be left up to the people to self-quarantine. And I don't think someone could force somebody to do that. So.
Yeah. This is a good question. If you think about it, there are some instances in which we certainly think the government should keep people safe, right? If the restaurant down the street from me here, people routinely went there, ate, and got food poisoning. We'd want the public health department to do something about that, right? They should go shut them down. They should give them a warning. They should make them clean it up. And if they don't, if it keeps happening, eventually they would shut them down, right? Because we do think that I have certain rights, but my rights end where your rights begin, right? And so if I'm going to make you sick, somebody ought to do something about me because you have a right to not be sick, right? And that's where the public health rationale ultimately comes in, is to try to keep other people, to keep people safe who want to be safe, even if other people are inconsiderate of them. And so we use that mandates for to mandate certain vaccinations for children before they go to school, right? If you're going to go into the public school, you've got to have your mumps, rubella, measles vaccine because the other kids need to be safe from you, right? And the question is, at what point is something a big enough danger that we're willing to say, okay, now we've got to shut you down, you know? And that's where the issue comes in here. And you know, with COVID, it's in a sense the perfect virus. I mean, from an evolutionary perspective, it it doesn't kill a very high percentage of the people it infects, which is its survival advantage, because then its hosts keep walking around with it, right? I mean, really deadly viruses tend to burn out as epidemics quickly because all the hosts die before they can transmit it very widely. This one, it lets you just keep spreading it. And it's even beautiful. The most mobile people, all you young people, get it and don't even know you have it. And you guys are going everywhere, right? You're in, and bringing it home to your grandparents. And then, oh, we're not. And so then the question is, how much can the government impose on you to keep me safe, right? And that's really the one that's being fought out here. And you know, with this particular pandemic, we have not handled it very well as a country generally, because in a way we've done it just halfway enough that we've dragged this out such that people are getting really tired of it. You know, when we did your first shutdown back in March, that was rather dramatic. And what we needed to do was keep shut down till we got those viral levels in the community way down so that only a few people were getting it, and get a lot of testing on so we could find those few people, contact trace them, and keep them isolated so the rest of us could all go about our business, right? But we didn't do that. We opened up too soon and the level was still way high. And so then we've been trying to, okay, how do we just contain it? And how, you know, okay, who do we close? We close the bars and the restaurants. So do we let the restaurants open outside, outdoors? And but then once the winter comes, can they open with certain half their capacity of customers? And we're driving everybody nuts with all this half measures because we have to do something. Because right now, our hospital here at Loyola is filling up fast. I mean, we are really in a second wave that is, you know, our ICUs are full again. And we're just at the beginning of this wave. We are going to have patients that are in hallways soon and not able to be treated. And so then it becomes, how much can we push on everybody else's rights to try to make sure we get this down low enough that we can treat the patients who are coming in, we get the number of patients down. And so it's really hard. And of course, some of it's just practical. You know, telling people what to do is hard. If they won't do it, you know, we're going to really be using the police on lots and lots of people. Well, that's not very effective. It really is better if we can persuade people. If we can get people to buy in that we have a reasonable plan, and everybody buys into it, and you're helping save lives by buying into the plan. That's just way better than using any kind of police force to enforce this. But unfortunately, we really just we've botched this one. You know, and so we're going to keep doing halfway measures. And I don't want to be too grim about this, but the truth is, we have Thanksgiving holiday coming up here, and there is a danger that, given where we are right now, with this thing, just the rates of infection soaring, that we're going to have a super spreader event on Thanksgiving that they're going to talk, historians are going to talk about for centuries to come. And the people are going to wonder how it was that we got into that situation where we did that. And truthfully, I'm terrified of that. I'm hoping that we still have a few weeks and enough people will get the message right now and just say, you know what, me and my immediate family are going to stay home together, and that's it, and not travel and see people. But I'm afraid, I'm really terrified that's not going to be what happens.
I have a question that ties in COVID and immigration.
Sure.
So the vaccine hopefully would be rolled out to the general public early mid 2021.
Right.
Is there going to be an issue where, because of their immigration status, they may not feel comfortable to receive the vaccine and have those 2 scheduled visits? Because it seems like most of them need, that's 2 doses.
Right.
And could that have an impact on whether we're getting control?
Yeah, and that's a $1 million question, and it's highly speculative what's going to happen with this. And as you point out, there's just the logistics of this. The great news is it sounds like we've got a very effective vaccine coming, and it's coming. Pfizer is the first one to publish their data. Moderna apparently has something very similar, and so we're going to have at least 2 companies producing it, which will help get it out there faster. It's stored at sub-zero temperatures, which is another logistical problem. As you know, every hospital in the country ordered multiple freezers last week, and there's that production problem even for that. So part of what's going to happen is all the health professionals are going to get it first, and that's partly just so that they don't spread it further when they're treating people. And also logistically, it's just easy. All this stuff's going to be dumped at the hospitals that have the freezers, and they're going to do it. Because right now, your CVS up the block doesn't have the capacity to store this. Hopefully, they will in time. But so we're going to people to some degree who can access it are going to get it first. As you say, it would be ideally we would give it next to all the communities that are hit the hardest by this, and the immigrant communities have been hit significantly harder than the people who've been in the U.S. for multiple generations, and that's for multiple reasons, right? Some of it is where people work in jobs, as we talked about, which can't be socially distanced, but also multi-generational households. Families in the U.S. tend to become strictly nuclear families once they've been here a while. Immigrant families are often multi-generational: grandma, grandpa, great-grandma, great-grandpa, and everybody is living with the grandchildren and their kids. And as a result, the young people bring it home and it hits the grandparents, and that's been a problem. So ideally, we'd want to get it to them next. But as you say, there's all sorts of things that are going to be problems. Are they in areas where we can get it to them easily? Is there the storage capacity? Are they near the kinds of places, clinics, hospitals that would have the freezers and be able to store it in the capacity, the volumes that are needed for them? And as you say, then it has to be made free because many of these people are uninsured. And the government, I understood, there is a contract with Pfizer for 50 million doses of this, which is 25 million people, because as you say, it's a 2-dose vaccine. So the government owns 25 million people worth of this. If it were to send it to those communities, get it to those communities, that would be great. But as you say, then there's the mistrust issue, that that many of these folks don't trust the health system already, as we've been talking about, won't want to initially come in for this. And the suspicion in the general populace is a little bit high right now. A lot of people worried about it being rushed and things like that, even though the standards for what we're seeing so far have been impeccable. There's really not any reason to be concerned. Other than that, let me always give you the caveat. With anything new, there can be sometimes a certain number of adverse reactions that we didn't know from the studies, right? Because the more people sometimes you have to give it to a lot of people in order to know that a small group of people get a certain kind of reaction, and that doesn't always show up in a phase 3 clinical trial. So, but nevertheless, the standards have been high on this, as high as they are usually. But I would be surprised if we are effective at getting this early to the communities that have been hit hardest. My guess is it's going to be the way things typically work. The healthcare providers will get it, then the people who are generally relatively well-resourced in life, who have primary care physicians and access to the hospitals that will have the storage capacity will get it. And eventually, this will trickle down. Places like your corner CVS will have a small freezer capable of doing this that will have it, and people will be able to go up the block and get it. And then we'll get to all these communities. Now, Dr. Fauci is being very optimistic. He's saying he believes that by fall of 2021, that every American who wants to be vaccinated will be able to get this. He's as in the know as anybody, but even he has no crystal ball, and things can go wrong, or things can go really right. I mean, while we're rolling this out, who knows? Maybe the attenuated virus version will turn out to work too. That would be way easier, right? Because that stuff that you could store that at room temperature. We could one dose everybody, But so there's great reasons for hope. Usually, though, the people who are hardest hit by things because of their socioeconomic circumstances are also the last people to benefit from the breakthroughs, despite our best efforts. When people talk about income inequality, I sometimes think it's a term that's misunderstood. Because it sounds like we want everybody to make exactly the same amount of money. What it means, though, is the people, when you get great income disparity, one group of people tend to get all sorts of negative consequences because of lack of resources. And these are the kinds of consequences we're talking about: basic health consequences and life expectancy and all of that. Oh my goodness, I have been with you for over an hour now. Have I kept you too long? Okay. Anything else I could say for your
I'm
I don't know. Oh, go ahead, Kate.
Nope, you can go ahead. Sorry.
Well, I don't want to take up too much more of your time, but this has been a great conversation, and thank you so much for it. My question for you is, how do you see things progressing as we move into the new year, as we move into having a new president, in terms of healthcare related to things with COVID and also with immigration? What are your predictions for a Biden presidency on those fronts?
Oh boy. Well, Dr. Fauci does not have a crystal ball, and mine is even cloudier. The attacks on the Affordable Care Act will stop, which is at least good, right? I mean, the Affordable Care Act that was passed under President Obama cut the number of uninsured people in the United States in half, which was a really big breakthrough. We had really made no progress. Our uninsured numbers have been going up. Now, for the last 4 years, with the various attempts to undermine the Affordable Care Act, the number of uninsured have been increasing, but we're still making progress. We had hoped that with the coming of the Biden administration, that the Affordable Care Act would be built on. That's what he's promised, right? That was what he ran on. And so that more people would get insurance and we'd fill in some of the gaps. And, because the Affordable Care Act was never a perfect law. Some of the plans have too high deductibles for the people who have them, and they avoid care and all of that. And that, so he will certainly try to do things to improve that situation. As you know, we're going to probably be dealing with divided government, where the Senate will not be in Democratic hands, and whether they're willing to work with him to come to some compromises to create some of this kind of legislation, that would be helpful. But it's going to be, I see at best incremental change coming on healthcare and immigration because we have divided government, and divided government doesn't produce very dramatic change. And so the president has power. They can, something like the Immigration and Customs Enforcement, under President Obama had originally deported lots of people. And I should say this again, to depoliticize this a little bit, he was called the deporter in chief by the immigrant communities because he set records. He had some of the early years of his presidency, 400,000 people a year were being deported. And he seemed to believe that if he showed he was tough on immigration, we'd be able to pass an immigration reform bill to reform our system. That didn't happen. But when it didn't happen, he then ordered Immigration and Customs Enforcement to take their foot off the pedal, focus on the borders, and leave the immigrant community in the interior alone. That those people have been here for 10 years or more that we were talking about, just leave them be. No raids at workplaces, things like that. So the president has that kind of administrative power to direct law enforcement to be either more aggressive or less. And I imagine the Biden administration will go back to that, so these communities won't feel terrorized anymore. But I don't expect a large amount of change. I'm hopeful that even with the Republicans controlling the Senate, a compromise can be worked out so that at least we get what's called the DREAM Act passed, so that the undocumented youth who have DACA, if no other undocumented immigrant is allowed to get a pathway to citizenship, that at least the young people who are covered by DACA are given a way to start to become citizens of the United States. But that will require a compromise, because again, probably not going to control the Senate. And so I'm hopeful that things will go in a more humane direction. I don't see dramatic change coming, and I think that's unfortunate.
Thank you.
All right, well, it's been a pleasure spending this time with you, and I'm always happy to come back sometime in the future. As I said, I enjoyed my trip out to Rapid City. I had no idea it was such a lovely city, and it's nice to be able to meet you. And truthfully, I hate to be so provincial. I'd never heard of your school before that visit, and so and I'm really glad to know that there is such a wonderful university there. To have a liaison with you. So, all right.
Thank you so much for
you.
taking your time. We appreciate it.
Have a good rest of the night. Bye-bye.
You as well.